Welcome again. Motivational interviewing and stages of change. These kind of go hand in hand, right? Readiness for change. And when you're talking to your clients, patients, this is some useful tools and strategies. And this is the Navigator Training Focus Series. We always offer CEUs for CADAP, CCAP, and now peer support specialist. So we're really happy if you're here on board with us. CA Bridge is a program of Public Health Institute, and we do share our materials and resources. So after this webinar, you will receive a post-event email with all of the information and the slide deck. So if you want to review, of course you can. For today's best experience, the only really tip I have to make sure is if you have a question, address it to everyone. Because if you put it to host and panelists, nobody else can see it. And so we know our navigators have very important questions to share. So as with every webinar, I begin with our CA Bridge model, revolutionizing the system of care. We have 3 focuses. You guys do this every day on a daily basis. Low barrier treatment, that's what your docs are doing in the emergency room, giving out the Suboxone, buprenorphine. I hear some people have instituted the alcohol use disorder protocol, so I'm really excited about that. But our docs are doing the low barrier treatment. The other 2, you guys, are your responsibility: connection to care and community and a culture of harm reduction. I know you were working heartlessly on these 2 topics for CA Bridge model, and you're doing a fantastic job. That's all I have to say is you guys always impress me. We've been to so many meetings lately, and I'm sure Chaia and LaToya can vouch that the work you're doing is phenomenal. It's just amazing. So thanks for saving lives and making a difference in people's lives every day. So we have some announcements. We continue our CHW certification guide. If you are in need of a CHW certification for Medi-Cal billing, if your hospital is going to pursue this, please check out our guide. We are offering that to our partnered CA Bridge partners. So please check it out. If you have any questions, please let us know. And it tells you right on there who to contact in case you do have questions. We offer our Navigator update monthly, and we have the next 3 months. We have December 11th, work-life balance, and then January. I can't think of January, you guys. Oh my gosh, 2025 is upon us soon. So those are the next Navigator updates. And then we have, again, our Navigator Focus series up until February. So what I want to highlight today is our October Navigator Spotlights. We're so excited that we're still have some wonderful navigators doing some phenomenal things out there, like I said. And for October, we had Jade Wilson, Yvonne Willingham, Ruben Luna, and Marcus Strong. So congratulations on your spotlight. Our objectives today, very simple, you guys. Demonstrate competency in engaging motivational interviewing for co-occurring disorders and for everything from SUD, mental health. You can use motivational interviewing for everybody and everything, including your children. Okay, if you need practice, use it on your children. Okay, use these tips and strategies. You will see results. They'll have a different focus. So please practice on your family if you have nobody to practice on. And then we're going to have the objective of identify the different stages of change patients may present, because we know is every single one of our patients coming through the ED ready to make a change? Yeah, not really, right? Some we see 2, 3, 4, 10 times, but it's okay with motivational interviewing. You're meeting them where they're at. Okay, so we have a poll. Aiden, can you put that poll up for me, please? I like to take polls. Have you seen an ED staff member approach a patient in a confrontational tone? Yes or no? I'm going to start today's webinar with seeing what is out there, right? What are you guys dealing with? Have you seen what not to do? Because I'm sure you have. I know I have. So going to give it a few more seconds here. It's give it another 30 seconds because it's a really easy question. And then we will post the results because I want to see how many. I know you guys struggle on this. I know some of you in the you're the only one in the hospital trying to be a role model for reducing stigma, making change, and introducing motivational interviewing, right? Sometimes you are the role model. So let's go ahead and close this. Let's see the results. All righty, 74. So 3/4, yeah, 74% have seen this. Okay, so you guys are living this, constantly. So hopefully today we'll give you a chance to refresh and review and get some new strategies going on. So why is it important? I think we all know if you do this actively, again, why is it important? It's not shaming and blaming, right? We've seen that's the 74% examples we've seen. And I've seen many colleagues. I've been a nurse for 30 years and I might have been one of those. I'll be honest. That was kind of what we were taught way back when in nursing school is, from the other nurses. Yeah, you tell them stop. If they're drinking, stop drinking, you're going to die. I don't know how many nurses have said that. And they speak in a really condescending tone about addictions. Again, it's their own personal biases. We can't change that. We all come with them this is who we are. But telling someone to stop alcohol, to stop fentanyl, is that really making a change? Bottom line, probably that person does not have education or training in motivational interviewing. I know until I became involved with CA Bridge, I didn't have it. So many healthcare, just to let you know, have not received formal training in motivational interviewing. It's a very small little blurb in mental health. So you may be the only one at your hospital that is the role model. So you are in this unique position of being a role model and how to talk to patients and engage them, right? How many of you guys do doctors and nurses come to you and are amazed because how come they're telling you that? Why are they telling you and not me, right? I hear all of you guys saying this, and it's because how you talk without judgment, without confrontation. So today we're just going to increase your knowledge, give you more techniques, more strategies, just to make sure that our patients receive our best. And so with that, I am going to hand it off to Chaia, and she's going to get into more about motivational interviewing. Hey, Chaia.
Good morning, everyone. Okay, let me figure this out. How to share my screen real quick. Okay, you see it? Yes, my presentation. Okay. Hold on. Let me pull this back up so I can see this too. All right. So, hi everyone. So, my name is Chaia Vang, and I am gonna go over motivational interviewing today. Um, I want to, as I go through this though, I want you all to be thinking about what are some of your most challenging patient encounters you have had in the past. Feel free to drop it in the chat. I love reading them, and if anything, we have time at the end. I could we'd love to talk about it too. Um, so for me, I still see many of you may still know that I am still a part-time, very, very limited time navigator. And I still see challenges within my own hospital when patients, especially when patients keep coming back and because they are not following up for whatever reason. Recently, we've had a particular female patient that comes in every evening. The last 6 months, she comes in around 10 p.m. to get her buprenorphine dose for 1 to 2 weeks straight. And all she needs is her Suboxone because she can't see her primary care doctor. She's waiting to see the doctor, or she lost her prescription, or she ran out. I think her last excuse was that she was nervous, so she dropped her bottle of prescription and it fell everywhere on the floor. And she never answers the phone when I try calling her. Every time she comes in and I've told like the provider, hold her for me, because obviously she's overnight. Hold her for me and so that myself or a social worker can go see her. She will either say she's already connected or she leaves AMA right after her medications are given to her. Um, so just thinking about like that particular patient as we go over motivational interviewing. Um, right. So what are the benefits of using motivational interviewing for our patients? Motivational interviewing approaches are associated with such great participation in treatment and positive treatment outcomes. I'm going to go over and we'll share this resource from SAMHSA. It's called Tip 35. All these information is from there, so I did not make this up. Um, so research has been shown that from 1999 to 2013, motivation interviewing has been associated with some small to very strong and significant effects that show positive changes in substance use behavioral health outcomes compared to having no treatment at all, such as enhanced patient engagement. As a navigator, you have the opportunity to create a non-judgmental, supportive environment for your patients, right? Much what Sherry's saying, patients would much rather talk to you than a clinician, a provider, or a nurse, because you go in there and sometimes it's the clothes you wear or it's just the vibe that you give to your patients. And then we prepare our patients to enter treatment, especially when we see them in the ER when they're withdrawing or presenting with other medical conditions. Um, we're already giving them what they're going to expect when they are ready to go into treatment. We're giving them that information that they need. Um, Also, much better outcomes when we use motivational interviewing. There's increase in participation, involvement, and retention in treatment. Patients have better outcomes, and the success rate, again, is so much higher. Patients also feel very empowered to when we show respect for patients to have autonomy. Patients can discover their own reasons to change when we start using motivational interviewing with them. We help the patients build confidence in their own ability to make changes. And then it reduces resistance and defensiveness, like when patients don't want to change, or they become defensive of why they're not changing or why they went back to using. And it's just so versatile. Motivational interviewing, as we have seen, can be used across different settings, and especially in the healthcare field. We've seen it in primary care of doctors. I know we have some navigators here from some FQHCs, and then our emergency departments. It's very common to use in counseling treatment centers. Now we're starting to see it in being used in education. And it can be delivered in such an effective and brief intervention that it doesn't cost anything to just use this technique. It also works very well in other different health and behavioral health changes, such as addiction, health behavior change, lifestyle changes. We all know we use the analogy when we compare substance use to a substance use disorder to diabetes, a patient with diabetes. Just stuff like that. Motivational interviewing would definitely help motivate patients to change. So, um, this is the need for change. Historically, patients in addiction treatment, patients must hit what we call rock bottom, or change only happens when someone's going through some kind of crisis, which is a very passive approach to motivation. Um, Evidence. Oops, did I miss a slide? Oh, wait, yes. Okay. Thank you, LaToya. Um, and if you know that evidence has shown that motivation can change at any point in time. Um, motivational interviewing is very influenceable, and very small interventions can spark a significant change. So your interactions, especially as a navigator, really matter. Um, and then that shows when patients have resistance, definitely reflects also in the interaction style when patients are kind of resistance to talking to doctors or nurses, right? And what they share with you as a navigator is just definitely different because of the way you treat your patients. Um, and trust is definitely developed through positive change. So, as a navigator, you have the skills to be genuine, respectful, and you demonstrate empathy. Your role is to help your patients recognize when substance use is inconsistent with their values or stated goals. So, you are not to teach or instruct or give unsolicited advice. Regard positive change to be in the best interest. You make the patients feel competent to change and you help develop a plan for change. And that's still the process of talking about change and setting goals to help strengthen their commitment to make changes. And then begin taking action, right? And that's when we initiate making that referral, that when the patients are ready, we initiate that referral, we make that appointment for the patient. Um, Also, we continue using strategies that lessen the risk of returning to substance misuse. So we help the patients identify personal triggers, develop some kind of coping skills, build support systems or find their support systems, create action plans, strengthen motivation for ongoing support. And last but not least, I know all of the navigators are sensitive and can be responsive to the cultural factors. um, so no, we all know that no one is totally unmotivated. That's why they came to the hospital, right? If they're not motivated, they wouldn't be there. Okay. And then I'm going to go over some new perspectives. So there have been different views on addiction and its cause to have influence in the development of treatment approaches. So not a fun fact, but an interesting fact is that in 1914, it was illegal for physicians to treat patients with drug addiction. So the only options for people back then with alcohol or drug use disorders were to place them in integrated homes or rehab treatments and asylums. Substance use was viewed as a moral failing or a disease that brought shame to families and judgment. But you fast forward that to the 21st century now, there is still some stigma that persists in addiction treatment. However, substance use is treated as a medical condition and there's evidence-based treatment available. As a navigator, again, you can really influence positive treatment outcomes, including guiding patients to treatment options, connecting them to care levels across all different healthcare settings, whatever it is they are ready for and what they want. Um, and then you address those barriers to treatment for our patients. Um, so first of all, we help patients identify and explore the desire and ability and reasons, competencies, and need to change their substance use behavior. Uh, we create an individualized and person-centered treatment, assess uh, and consider during intake, and we offer them a menu of options that can include medication-assisted treatment, or just harm reduction services. Um, we try to use the person first language and we model that so that the rest of our staff can also see that too. Um, and then also, like I said, being very empathetic and understanding and supporting the patient, not being authoritative or like powering over them. Um, and then we make focus on early and brief interventions, which is definitely when we make the referrals to the treatment programs as necessary. And that definitely helps decrease the emergency room visits. Um, and also be very accepting of new treatment goals, which can be a very broad range from just improving their health and psychosocial functioning, improving some their employment status, when having them get ready to go back to work, or just reduction in crimes. So that could be like the range of goals can be very different for our patients. We know that not just it's not sometimes it's not just stopping drug use, it could be something else that they want. That's why they're there in the hospital. That's why they're there to see you, because they want something else. They want help. Um, and then also reduce the risk, focus on reduce risk of use. So like I said, offering the medication assisted treatment, whether it's for alcohol use, opiate use, or just reduction in substance use. So many people with substance use treatments do not seek medical addiction treatment, but have often entered the healthcare system through general medical settings. Um, we know that especially when our patients come through the ED, right? That's why we have our emergency department navigators to initiate and bridge that gap to get them started. And that's why we have our navigators there to provide that brief intervention that is needed. So your task is to help patients become ready, willing, and able to change. This acronym here, WAR, is to help you through those steps. So W is willingness, is linked to the important place on a person, places of changing. Wait, and how much a patient is wanted or their desire to change. Ability is the extent to which a person has the necessary skills, resources, and confidence to make a change. And you can help in doing that by identifying the barriers. And then readiness, which the final step in which a person finally decides to make a change in a particular behavior. So remember that patient that I shared at the beginning that comes in at 10 p.m. Um, it took a while. It did take a while to finally reach her, right? But after 6 months, it finally saw her on a random Friday. She came in during the day. And so while talking to her, she expressed that she had wanted to connect to a program because her doctor that she was seeing wasn't able to manage her needs. So I did make an appointment that did an intake over the weekend. So the next day was going to be Saturday. And then but she had to go in at 3 p.m. But guess what? She still came back to the ED over the weekend at noon on Saturday and a Sunday again. So just thinking about this patient, she has some willingness, but how ready was she to be connected? Or was she just choosing the route that she was familiar with, which is coming to the ED until her doctor was able to see her again? What stage of change do you think she's in? And just, think about that. And I'm going to go over the stages of change really briefly. So as a navigator, you can enhance a patient's motivation for positive change at each stage in the stages of change process. So some of the key points, I'm gonna try not to like go so much into detail with what every step is, what it means and stuff, but I'll go over it very briefly too. So most people in the cycle of change will either go in either a circular pattern or some kind of spiral pattern, not so much linear, so not from like pre-contemplation to action, um, or maintenance down to like preparation. They will go either back and forth in stages or through the cycles. So in pre-contemplation, it's when you can build trust and with the patients and raise their talk about their doubts and their concerns. As a navigator, you can build awareness and behavior change by building trust with your patients. And then in contemplation stage, you can explore the pros and cons of change with your patient and the patient's values about change in substance use behavior. In preparation mode, plus the preparation step, you can help identify a patient goal and develop a plan to change. offer this is where you can offer the menu of change options here. Explore low and explore barriers to help the patient be ready for action. And then in the action step right here, you can support the patient's steps to taking action. Help the patient determine which stage strategies are working and which ones are not. Change the strategies if needed. And here in maintenance right here, you support the patient's lifestyles changes, engage and retain the patient if they are in substance use treatment. Create some kind of coping plan with them, identify new behaviors that reinforce change, identify what the resources they may have that may be beneficial for them, such as their values, knowledge, skills, family support, community support. That's here in maintenance. Usually when I see patients return to the ED because of a missed appointment or at the clinic or they're waiting for insurance to fill the prescription, it's usually here in the maintenance because they don't want to go back to using. And right here in this stage right here, that's called relapse and recycle. This comes from the SAMHSA guide, but then we try not to use the word relapse. So I'm gonna use reoccurrence or return to substance use. So when the patient returns to using, and they temporarily exit out of the cycle of change. So return to use after a period of abstinence does not mean the patient has failed or is no longer in recovery. And it's also important to know that it's very normal. Patients cycle through these different stages several times before achieving a stable change. And what you can do is help the patient re-enter the cycle of change. And I want to share what Tommy, if you guys know of Tommy, he's our longest mentor. He always talks about welcoming patients to come back to the ER whenever they want to, because he knows that they know where to come back and get help because they trust him. It doesn't matter where they are. He would rather see them in his ER alive than not alive. Um, so I am done here with my part, but before I hand it off to LaToya, I want to see if you all can share with me what is the most common stage of change that you see during your first encounter when you see your patients for that first time in the ER. Contemplation, right? Contemplation, pre-contemplation, yes. Okay, thank you so much. All right, LaToya.
Oh, that's the wrong slide. I don't normally share slides, so give me a moment. Okay. Can you guys see my slides?
Yes.
I think it looks a bit funky on the screen though, so I apologize. All right, so there we go. And we're talking about the clinical significance of motivational interviewing. So, motivational interviewing is really important, as you heard already, all the great benefits that you get from motivational interviewing. It really helps to reduce any resistance that you might be experiencing, especially as many of you have said already in the chat that you're, encountering patients in that like pre-contemplative stage, or maybe a combination of contemplative and pre-contemplative. So this method of engaging with patients will help to reduce some of that resistance. We've already heard how motivational interviewing can also help to empower the patient so that they can take ownership over their own change process. That's really giving the patient autonomy to make decisions that they're the ones living with, right? So they're the ones that are going to be going through all of these steps. And doing these things. So it's important that they have that autonomy. And then when you're met with that resistance, motivational interviewing really helps to allow you to walk alongside the patient, so that you can help them shift from that ambivalence toward change. And it's important to understand that walking alongside the patient means that you're not leading them and you're not coercing them. You're not trying to convince the patient to go into treatment. It's basically going off of what the patient is wanting and what they're willing, ready, and able to do. So when we're thinking about motivational interviewing techniques, I want to highlight some differences between coaching versus blaming and shaming, and what those things might do when you have an encounter with patients. Love that, Sabrina. I learned that we are not fixers, but helpers. Absolutely. So you are helping, you're not fixing. Yes. Okay. So when it comes to coaching, I'm going to move my little chat box here. I may not see all your chats. Okay. So when it comes to coaching, it's more of a individualized and person-centered approach, which promotes growth, helps the person find their own strengths, and encourages their own personal development. As opposed to taking a more generalized approach through blaming and shaming, that tends to point out mistakes and does not really offer constructive guidance. Supportive and taking a supportive and collaborative approach promotes self-confidence and helps patients recognize their own achievements, whereas negative and dismissive approach is kind of a blaming shaming that tends to lead towards defensiveness, and feelings of shame lowers the person's self-esteem. You might get comments like, why are you even talking to me? I never said I wanted this. Things like that, because they're coming from a place of defensiveness. Empowering the patient versus, sorry, I skipped a little bit. So you'll want to empower the patient and not undermine their self-efficacy. In doing that, it promotes positive relationship building, utilizes, as we've already heard, the importance of showing empathy, which is definitely not the same as sympathy. And then building trust, allowing the patient to feel safe disclosing information. Taking a non-judgmental versus judgmental and confrontational approach can also have these same benefits of helping to build that positive relationship, helping the patient feel comfortable disclosing information to you. And if we're taking a blaming and shaming approach, that can usually lead to mistrust, and can result in hostility. I'm sure many of you have encountered some hostility. I know I have, and it's not fun. But sometimes it helps us to reevaluate our approach and what that person perceived. And so it could also a blaming and shaming approach can impede the patient's ability to move toward change because they're going to be in this really defensive kind of mindset. And then so under coaching, you'll focus on next steps versus focusing on past events. So once you've empowered the patient, you've built this trusting relationship, you're highlighting their strengths and achievements, then you can talk about next steps, and it kind of flows pretty naturally. And is looking towards the future as opposed to blaming and shaming leaves the patient feeling stuck, or they're in that stage of ambivalence and they're focusing on past mistakes and they're really unable to move forward. So some models that we'll see for motivational interviewing, some of you, I'm sure, are very familiar with the next one, which is OARS. I have a few others that or a couple of others that I'm gonna go over, but so OARS is, and you guys can drop it in the chat. You can even feel free to give some examples in the chat. But I'm just going to go over what the acronym stands for. So O is for open-ended questions, A is for affirmations, R is for repeat rephrase, but also sometimes people say it as reframing. And then S is for summary. So when you are utilizing OARS in motivational interviewing, it's a really great approach to take because motivational interviewing can be used, as we've heard already, for co-occurring disorders. So it could be, standalone substance use, or it could be a combination of substance use and mental illness. It could be a combination of substance use, mental health, and medical illness. So all of it, which can definitely benefit from using motivational interviewing. The motivational interviewing approaches can be modified per individual. So it also allows motivational interviewing to be adaptable for people who might have learning disabilities or cognitive impairment, things like that. And so anyhow, so going back to OARS, so when we're talking about open-ended questions, reflecting, yes, I forgot about that one. Absolutely. So R can also be reflecting. Thank you, John. Or when we're talking about open-ended questions, something that you could ask that is an open-ended question that would sound something like, what are your goals for your health? Or you might ask, what do you think helped you get better? Or even say something like, tell me more about that. Those allow for more than just a yes, no answer, and allows the patient to be able to give you more information. For affirmations, that might sound something like, it sounds like your job is very important to you and you don't want to lose anything or anything to get in the way of you keeping your job. Or something like, it sounds like you're really committed to not giving up. So that it can vary how those affirmations come out, but you're listening to what the patient is saying, and you're, kind of putting a positive spin on the information they're giving you. And then for repeat rephrase, that might sound something like, it's hard for you to imagine a reason why you might need treatment. Or so you're saying you probably won't need another treatment ever again. So this might be for a patient who's feeling a little ambivalent and is in that pre-contemplative stage, or even the contemplative stage, and they're trying to gauge whether or not treatment is right for them, or maybe they're saying like, I've tried it all. And then with summary, you can say something like, you're willing to cut down your use and keep treatment in mind. So just summarizing kind of that conversation, and you want to do it in like a brief, succinct way. Or you might say something like, okay, so you want to keep your job and you're ready, willing, and able to start treatment today. So that's essentially what some of ORs might look like. Moving on to frames. Frames is another acronym. This really helps you to hone in some of those motivational interviewing skills. So frames frames stands for feedback, responsibility, advice, menu of options and treatment alternatives, empathetic counseling style, and self-efficacy. So for F, we will want to be able to give patients personalized feedback to allow, personalized feedback about their substance use. And it's a way that can help them understand and kind of see what their health risks are, or kind of risky behaviors. I'm not going to go through all of these because for the sake of time, but I wanted to touch base on A. So A is giving advice. And I want to just kind of clarify for advice giving, this is not unsolicited advice. We are not in the practice, especially with motivational interviewing and taking a person-centered approach. We do not want to give unsolicited advice. So advice in this aspect is talking about providing education to the patient. So it's not going to come off as if you said something like, you probably should go to treatment, or you really should stop drinking, or something like that. Like that's kind of giving advice that may not necessarily be very helpful and may not be wanted. So another way that you can provide advice is through education. So, the doctor said that your liver is struggling a little bit, and that cutting down your drinking may help. May help improve your health. And so I can help you work on a plan to cut down your drinking, or something like that, versus just like, you should stop drinking. And then I really want to emphasize, which I'm sure many of you who perform navigation for substance use disorders, many of you are already doing this, but keep in mind the menu of options. So treatment alternatives and other resources are always recommended and very needed by our patients. We never want to just come with one treatment option. Give them the whole menu. Give our patients everything that's available to them, and let them choose. Don't forget about the patient's autonomy and making decisions for themselves, and truly being a part of that decision process, because again, they're the ones living this life and doing these things. So provide a menu of options and allow them to pick what's doable for them. All right, so I'm going to go to the next one, which is darn cat. So some of you may be familiar with darn cat, some of you may not. It makes me smile because it just sounds funny. But darn cat is kind of like a twofold in this acronym. So it stands for desire to change, ability to change, reasons to change, need to change. And then CAT is commitment, activation, and taking steps. That's a lot, but I'm just going to give you a brief overview of what some of those things might sound like. Excuse me. Darn cat is helpful to being able to recognize what that change talk might sound like. So not only are you implementing, these aspects of motivational interviewing and you're taking this different approach, but darn cat or the darn part helps you to listen for and recognize, to be able to identify some of that change talk within your patients. So you might hear, as far as desire to change, you might hear this expressed as a statement of wanting something different. And that could sound like, I want to cut back my drug use, or I want to cut back my drinking. They might even say something like, I hope to start AA, or I've been thinking about starting AA soon. And then for ability to change, this may be expressed as their self-perception of their capability to like implement this change. And that could sound like, I could drink water in between beers or in between, shooters of alcohol. So they're visualizing that in their mind of like what they are able to do. And then for reasons of change, is their own kind of internal argument of why they want and should and need change. So this might sound something like if a patient was saying, I'd probably miss less time at work, or if they started treatment, or my friend said people at AA are supportive, I could use that support. And then the need for change could be expressed as something like, I have to stop drinking, or my health is at risk if I don't get my drinking under control, or if I don't get my drug use under control. It could even sound something like, this overdose really scared me. I don't want this again. So Darn Cat helps you to be able to recognize what some of that change talk sounds like. And so once you hear that change talk, then you can also figure out, using the cat part, of where that patient is in those stages of change. So commitment towards change might sound something like, I guarantee that I'll start AA this weekend. I'm going to make that appointment. Or they might actually say it as a promise, like, I promise to go to this appointment. Activation is sometimes expressed as, I'm ready to do something about my drug use, or I'm ready to go to my first AA meeting. And then taking steps can be expressed as, I haven't used since the last time we talked, or I cut down a lot. I'm not using as much as I was. Or it could be something like, I avoided a party where I knew my friends would be doing drugs and drinking there. So again, just reiterating, once you are getting in the groove of the motivational interviewing practices, understanding what those stages of change are, and then the Darn Cat really helps you to be able to identify what that change talk looks like, so that you can start implementing, those other steps. And so I'm going to go on now to the case study. We have a really brilliant and beautiful case study set up to review. Chaia and myself will be going over it. Let me make sure that's okay. All right. So I'm going to go ahead and read the patient scenario. Let me get my notes together. Sorry. Okay. So this is the patient scenario. So we have a 46-year-old Hispanic woman with alcohol use disorder. She's been admitted for jaundice, and she currently has liver hepatitis. She is in need of a liver transplant, which may take longer than 1 year. She currently is consuming 1 pint of alcohol per day and has been doing so off and on for the last 20 years. Her last drink, she reports, was 3 days ago. And she has history of 9 DUIs, the last of which she was just released from prison 1 year ago. And she is unable to continue oral naltrexone because of the condition of her liver. So the doctor basically comes to you as the navigator and says, look, this patient is going to die if she does not get her drinking under control. And she's not going to get a transplant like that if she's still drinking. Okay. And so they're like, go talk to her. Go talk to this patient.
Right. Well, hi, LaToya. I am Chaia, the navigator here. How are you feeling right now?
I'm feeling pretty terrible. The doctor said that I need a new liver, but that's not going to happen if I keep drinking, but I can't stop drinking.
Well, I'm glad you're here, and that is the first step. So thank you so much. What does your drinking look like now, and when was your last drink?
I typically drink about 10 beers a day, but sometimes more. Like when I get my check at the start of the month, you know, I might get a little bit more. I last drank 3 days ago.
Okay. Tell me what did work for you in the past, or what you try, or have you tried to cut down before, or quit before this?
I've tried to cut down so many times. I've been to 40 different treatment programs, like residential, AA, stuff in town, stuff out of town. Um, they do work. I do really good when I'm there, but then it doesn't last when I get back home. The naltrexone was helping, but I can't take it anymore because of my liver.
So I hear you saying that you have had some experience with cutting down on your drinking, and then you do well when you're in a residential program. The medication was helping, but since you can't take it anymore, you're finding it difficult to stay away from alcohol. What does your support system look like when you do get home?
All of my family wants me to stop. Um, they will call and check on me. So like when I'm not drinking, like they're like all calling, checking on me, like making sure I'm doing okay and stuff. But like really nobody is there all the time. So when I'm by myself, that's when I want to drink. I don't want to die. I can't stop thinking about drinking. Um, it's all I think about all the time.
It sounds like you have a good support system and might just need some additional support for the times when you're by yourself. What are your goals today?
Um, be well enough to go home, I guess, or is my goal for today. I could think about a meeting down the road sometime, but just not right now. My liver's too sick. It's cold and rainy outside, so maybe when it warms up again.
Okay. LaToya, I'm really grateful that you accepted just talking to me today. I understand you're going through some difficulty with your health. You don't want to die, and it's definitely a struggle to stop drinking. I love to help you when you're ready. This is my number. Please reach out if you want to talk or get help connected to treatment. Can I ask, is it okay if I call you once you do leave here?
Yeah, that's cool. You're sweet and you seem like you really care, so I'm okay with you calling and I'll save your number.
Okay, that's it for our case scenario. Do you all have any feedback that you want to share? What could I have done as a navigator? Thank you, Mira.
as you guys are considering and contemplating what feedback you might have for our nifty little role play, I'm gonna just show you the next slides that we have because we have about 4 minutes left. We have a knowledge check that you will get these slides in a thank you for the good acting comment. You will get these slides in a post-event email. So I highly encourage you to do the knowledge check when you have a little bit more time on your hands. These are some really great questions to just kind of test yourself on how well you were picking up what we were putting down for you today. And then our resources are always available to all of you on our website. Please feel free to rummage through all of the plethora of resources and reach out if you can't find something, or maybe you are unsure what it was called and you thought it had a different name. We can help you with that. We're typically using the website every single day, multiple times a day, and I guarantee we can find it pretty quickly. Contact us at mentors@cabridge.org if you have any questions, comments, if you need anything from us, even questions about your CHW certification or whatever it is. And don't forget about our Chaia Bridge Academy. We have CEU available with our training modules for CADTP, CCAP, and we're working on putting up some of our new content as well. Our Chaia Bridge Academy is free and has content for substance use navigation, nurses, and for your providers. Yes, a recording will be available of this webinar and will be sent along with the slides in the post-event email. And then this is our really great director, Sherrie Cisneros, and Sherrie's contact information. So I'm gonna stop sharing just so I can get to the chat here. So I see some really great feedback here. You ask about their ambulatory status. Yeah, that's really great. Can they manage going to a program? That is actually a super, super great point because that could be a challenge or a barrier. And yes, so telehealth services is a good idea. And we really want to emphasize that sometimes, which all of you probably know this, but sometimes that first conversation and that first encounter with the patient may not lead directly to treatment yet, right? They might not be ready for a change quite yet, but we're planting that seed and we're going to be there to support them when they are ready. And so at the next conversation, that might be where we talk about telehealth services. Excuse me. All right. I would love to continue the rest of these questions and the conversation during office hours, which is right now at 12 o'clock. We are at time for this webinar. So thank you so much to everybody who joined us today. If you can join us for office hours, please do. It's a half hour where we talk about anything and everything substance use related for navigators. And thank you. Have a great day.
Bye, everyone.